Dr. Dhaliwal is with us here for the next talk, sir.
Thank you very much, madam, for allowing me to share my views on manual SICS in Indian scenario. I will be presenting a series of evidence-based data which I have gathered from the recent journals which tell about the scenario of MSICS in Indian subcontinent, and the work is mainly done by Indian authors. So first of this data is about a systemic review and meta-analysis about the cause of preventable visual loss due to cataract, which says, and refractive error, both are reversible and continue to be the most important and common cause of blindness under over 50 years of age. Most recent studies from WHO reveal that about 47.8% of global cataract blindness, and in Indian subcontinent is about 51%. And cataract surgery has been viewed as one of the most cost-effective health interventions. Now, cataract surgical rate, which represents the number of cataract operations performed annually per million population, in developing countries is usually between 4,000 to 6,000. And in last 20 years, in India, it has dramatically improved from 1,500 to 4,000. And what it is all about. Most of the states in India, as you can see, Gujarat, Pondicherry, Tamil Nadu, Andhra Pradesh, they have more than 4,000 CSR, and this has been attributed to the WHO efforts which has brought this dramatical change, and Nachir and all have advocated through their studies that high volume, high quality cataract surgery is the approach to maximize productivity in our country particularly, and with a reported surgical time of 3.5 minutes, and we have just seen a surgeon performing surgery in less than 2 minutes. So MSICS takes less time than Phaco, Ruetinol and Gogate and all, they say 15 minutes versus 9 minutes, and it is most cost effective also, as shown by many studies. Rupees 1978 versus rupees 720 in one of the studies. So MSICS offers a similar advantage to phacoemulsification, but due to less surgical time, low cost, wider applicability, it is more popular in developing country and underdeveloped countries. With a huge amount of cataract surgical load in our country, probably this is the best choice how we can reduce the cataract blindness in our country. Most of the studies, they support the same view, and recent innovations such as low cost intraocular lenses have added the advantage of SICS to our regime. Manual extracapsular cataract surgery occupies an important role in cataract surgery nowadays, but it cannot be a replacement to phacoemulsification in Western countries, but should be a part of cataract surgeons' overall skill. Why? Because there is a definite advantage that phaco gives over SICS as far as astigmatism is concerned, but the rate of nucleus drop is higher. Every one case in 25 needs to be bailed out, and in bailing out, SICS proves to be a better technique as compared to simple ECCE. There are no difference in the endothelial cell loss, though there is a significant difference in the surgically induced astigmatism. Meta-analysis to compare the safety and efficacy of a small incision cataract surgery says that the average time of SICS is less. There is no difference between best corrected visual acuity between phaco and SICS. The only difference is that the statistically greater astigmatism due to SICS. This surgery was done by us, which evaluates the various techniques of SICS, nucleus delivery, and it says that ACM and visco expression are the most effective techniques for early visual rehabilitation. A study was done at Gujarat which says that refractive error and posterior capsule opacification are most easily treatable post-operative causes of visual impairment, and hence it can be handled. So just to summarize, in a country like India, where we are having the load of cataract blindness to the tune of 51%. The cataract surgical rate has magically improved, and that is the magic of SICS, the theme of today's session, from 1500 to more than 4000 in most of the states. So the crux of this story is that MSICS is still the surgery of choice in the country like India, where we have to think for options which are less time consuming, they are most cost effective, they can be implanted to a larger population with as good results as phacoemulsification. And before I end my talk, I would like to draw attention towards the city from where I come. That's the capital of Madhya Pradesh. It's called City of Lakes. You all must be knowing Bhopal for gas tragedy and Sanchi, but most of you must not be knowing that it hosts another very important World Heritage place, that is Bhimpetika rock shelters, which are, as they are known for their cave paintings, and that is the oldest known human inhabitant, that is more than 1 lakh years. So I welcome you all to the City of Lakes. Thank you very much for patient hearing.